Okay, it's 1 minute past 5. Warm welcome to our virtual Grand Rounds in Radiation Oncology. You know our format. We aim to present you the latest science presented by the top speakers in a very interactive format. And I can promise you already today, this is certainly a highlight of our series. It's happening every first Wednesday of the month. Usually we have it only for 30 minutes. Today, we allowed ourselves to extend it by 15 minutes, 45 minutes in total, because we will have not only just one, but two randomized trials, which we will be discussing back to back. Special thanks, of course, to the societies which have endorsed our format, the Astro Society, the Swiss Radiation Oncology, and the German Society for Radiation Oncology. And also a quick reminder that all our sessions are being recorded. So if you have missed any of them before, just go to our web page and have a listen to them. Today, we are really privileged to have two very important clinical trials which will be discussed, the PACE-A and the PACE-B trials, and virtually they have just been published in a few days ago. One study, the PACE-B trial, the 5 years results in the New England Journal of Medicine, and the other one, the PACE-E, in the European Journal of Urology. And it's an absolute pleasure and honor to welcome Professor Nicolas van Ers. He's the medical director of the Royal Marsden. He's professor at the Institute of Cancer Research. He's leading the stereotactic program at the Royal Marsden Hospital. And of course, he's being the PI of the PACE-A and PACE-B trials. And he told me a secret before, he's not really fond of these virtual meetings. So it's an even greater pleasure having you here today and discussing with us the PACE trials. Nick, many thanks for joining, and the floor is yours.
Thank you. Let me just get my slides up. Okay. Thanks again for the very kind invitation. As we were joking, I think we've all probably had enough of virtual meetings, but I think the importance of this as an educational format is high, and I'm also I'm delighted to be able to share the PACE data. So you asked me to have a title for this talk, and we've gone for SBRT for localized prostate cancer, the new standard of care. So these are my disclosures. I have received research grants from Accuray and Varian, both for the PACE trial and speaker fees from Accuray. So the PACE trial is an umbrella trial testing SBRT for localized prostate cancer, and I'm going to talk about two of the studies in the umbrella today. The common things to both of these studies were the patient eligibility. The patients were identical eligibility for both trials. There had to be T1C to T2C, Gleason less than 3+4, less than or equal to 3+4, a PSA less than or equal to 20. Patients had MRI staging, and there was no androgen deprivation given in any of the arms of either study. The common theme was the experimental arm in both studies. The experimental arm was 36.25 gray delivered in 5 fractions in both of the trials. So this is what the umbrella looks like. So patients had localized prostate cancer. So PACE-A and B are on the left. So low and intermediate risk cancer. If patients were choosing surgery as their primary modality of treatment, they could randomize in PACE-A, and they're randomized between robotic-assisted surgery or SBRT. If they were choosing radiation as their treatment modality, then they could randomize between conventional fractionation, which when we started the study was 678 gray and 39 fractions, but following the publication of the CHIP trial and other trials, we changed that to a 4-week schedule of 62 gray and 20, and the experimental arm was 36.25 gray in 5 fractions. PACE-C is a study in higher risk cancer, which I'm not going to talk about today, as we don't yet have results from the PACE-C trial. So PACE-A, so as Matthias said, this was recently published in European Urology, and we're delighted to have it in European Urology because I think it's important that the surgical audience can see this data. So that's why we chose to go for European Urology as opposed to an oncology-specific journal. So as a reminder, PACE-A, that's the arm And just to take you back to when we designed it, it was in 2011. And at that time, Da Vinci was becoming a much more common modality. It wasn't yet the standard of care for surgical treatment of prostate cancer. I think we'd all agree now that it would be unusual in a developed society for a prostatectomy to be conducted without robotic assistance, but it wasn't at the time. So it was an emerging technology. And also, SBRT was an emerging technology. At the time, most of the SBRT delivered around the world for prostate was being delivered on a CyberKnife. And so we kind of envisaged this arm of the study as a bit of the battle of the robots. So that was the schema. So again, patients had to be T1C or T2C, Gleason less than 3+4, PSAs up to 20, MRI staged with no androgen deprivation, and they're randomized on a 1-to-1 between surgery and SBRT. So there were two co-primary endpoints. In fact, when we originally started the study, it was going to be an oncology endpoint, but the numbers were going to be way too high. So we had a protocol amendment to change this to a co-primary endpoint, and we expected that urinary continence would be worse following surgery, and we thought that bowel function would likely be worse after SBRT, and we didn't want to prioritize one over the other, so we had two co-primary endpoints. The secondary endpoints were patient-reported outcomes, clinician-assessed toxicity, biochemical and clinical failure, disease-free survival, and overall survival. So these are challenging studies to recruit to. The sample size was aimed at 234 patients, and this gave us an 80% power. We expected, and this was from the surgical literature and also talking to a number of surgeons, that the pad wearing, which is how we define continence, would be 15% for surgery patients, and we estimated around 4% for SBRT. With that, that gave us a 90% power to detect a difference in epic bowel bother. So it gave us good power for both of the primary endpoints. So recruitment started slowly, it then picked up, and then unfortunately we hit COVID, where we essentially almost stopped completely doing prostatectomies in the UK for almost at least a year, and the recruitment almost stopped, did stop completely. And at the time we'd randomized roughly 120 patients. What then happened is the IDMC, our Independent Data Monitoring Committee, actually looked at the data and they saw the results that you're going to see. And they said to us, there's no point in recruiting another 10 to 20 patients, unlikely to meet the 234. And they suggested we stop the study and publish the results at that time point. So at that time point, we had 60 patients randomized to surgery and 63 to SBRT. You can see the risk profile. Most of them were intermediate risk patients. We're very proactive surveillance in the UK, and so the lower risk patients, although eligible, don't tend to be treated. So most of the patients had intermediate risk disease. This is a slightly complicated flow chart, but there were patients who didn't receive the planned treatment. And so in the end, we were left with 46 patients for analysis in the surgery group and 56 in the SBRT group. So the results, and remember we had two co-primary endpoints. So we defined urinary continence. So this was the proportion of patients wearing urinary pads at 2 years. And in the surgery cohort, that was 50%. And in the SBRT cohort was 6%. And this was highly statistically significant. And obviously was significantly higher than we expected. Important to see what happened over time. So immediately after surgery, a very high number of patients were wearing pads. That improved over time, but after about 9 months, it pretty much remained static, and the patients still remained at least wearing one pad. And that is important because across the trial, patients were about 88% of patients were only wearing one pad. So these aren't people who are profoundly wet. But I think what's important is, if you're a patient who's about to undergo a prostatectomy, I think you should be aware that you may be wearing at least one pad a day. Even if it doesn't trouble a lot of men, I think people should know this before they make decisions to have a prostatectomy. So on the bowel bother, so this is the EPIC bowel bother. So a perfect score is 100, and profound, like bad bowel bother, is sort of 20 or 30. It was very good for surgery, 97.3. And good for SBRT, but slightly worse in surgery as expected at 88.7. Relatively small number when you see the PACE data. In fact, the figures were very similar to surgery. But in this study, it did show that SBRT had slightly worse bowel bother than surgery. And that's just a box and whisker plot which shows that over time. But I think it's important to look at what the bowel bother was. So no problem was the majority of patients in both. A very small problem was higher in SBRT, so 15 patients versus 3. And a small problem, again, was higher, 6 versus 0. A moderate problem, only 1 patient had a moderate problem across both arms of the study. So although it was significant, the actual bowel bother was fairly minimal. Now, I think although this was not a primary endpoint, I think this is very important. This is sexual function. Again, an EPIC score, which would be perfect, is 100. So for surgery, it was 26.5, and the number in brackets is the standard deviation. And for SBRT, it was 59.3. So very significantly better following SBRT than surgery. And if we look at this graphically, so you can see that about 25, a slightly higher proportion of patients did not have perfect sexual function at the start of treatment. So men were already suffering from a degree of sexual impotence. The green line is SBRT. You can see it drops slightly and then picks up a bit and then remains fairly static. There's a big drop in the surgery. It does pick up a bit, but it gets nowhere near back to baseline. And again, I think this is very important information for patients to be aware of before they choose either SBRT or a prostatectomy as their primary modality. So these are just the other EPIC scores. So urinary incontinence, again, green is SBRT and blue is surgery. So urinary obstruction, almost overlapping. Bowel subdomain, very, very close. And again, the sexual subdomain, a big gap between the two. And these are the actual scores for the EPIC subdomain. You can see that there was significant differences in 3 of them, which is urinary incontinence, urinary and irritative symptoms, which is slightly worse for SBRT, urinary bother, no difference. So although patients were wearing a pad, when asked about bother, there was no difference. And sexual bother, there was a very significant difference. Interestingly, when we got clinicians to measure the toxicity, this is CT, CAE, GI toxicity at 2 years. There was 0 grade 2 toxicity at 2 years. So if we'd used this as our primary outcome, we would have missed the difference completely. So it is important for this kind of study to get patient-reported outcome. Similarly, for GU toxicity, there was no difference in the clinician reported. Again, so if we'd not got patient-reported outcomes, we would have missed what I think is a very important finding. So we concluded from PACE-A that compared with surgery, patients receiving SBRT reported better urinary continence and less sexual bother at 2 years. However, SBRT patients did report slightly worse bowel symptoms at 2 years. We will be publishing the efficacy data. That will be towards the end of next year. Obviously, it's a small study and not powered to detect a difference, but we will be publishing the oncological outcomes. I'm not sure the meeting it'll go to yet, but it'll be available and ready to publish the end of 2025. So we'll move on to PACE-B. So a reminder, this is the overall flow chart. So if we remove PACE-A and C, it's patients with low and intermediate risk cancer and those who are having radiotherapy, and they're randomized between conventional fractionation, or I'm going to call it conventional, but it's actually moderate hyperfractionation, and SBRT. And as Matthias said, we're delighted that this study was published in New England recently. And in our game, it's not actually that common to get a straight radiotherapy study into New England. So we're very pleased that they did actually accept it. By the way, they took a long time to publish it. If you go down that route, be patient. So this was 874 patients, T1C to TTC, Gleason less than or equal to 3+4, PSAs up to 20, MRI staged, and importantly, no androgen deprivation in the study. And also the NCN risk groups didn't exist at the time, so we didn't base it on NCN. I decided at the time that patients with 4+3 probably needed androgen deprivation, and I didn't want any androgen deprivation in the studies. I thought it might confound the fractionation question. so we excluded 4+3s. They were randomized on a 1-to-1 basis. The conventional fractionation, as I've explained, started at 78 gray, but then moved to 62 in 20. And the SBRT was 36.25 in 1 to 2 weeks to the PTV, was the CTV, which was the prostate only, got 40 gray. And these were the primary endpoints, was biochemical or clinical failure, and the secondary endpoints were overall survival, disease-free survival, and the clinician reported toxicities as listed. So this is the characteristics of the patients. So the median age was 70, and if you recall, the median age in PACE-A was 65, which is not surprising, having a younger median age in the surgical arm. If you look across most radiotherapy studies, the median age is between 69 and 70. So this is a very common median age for this kind of trial. Again, important to note that most of the patients with intermediate risk disease, most of the low-risk patients get active surveillance. There will also be in some patients who are classified as low risk because they had Gleason 3+3, but would have had MRI progression and not been repeat biopsied. So they may have been classified as low risk, but there was a decision to treat them based on MRI. So there's probably even less of what you call a genuinely low-risk patient in this trial. The New England, of the 6 reviewers, 5 of the 6 reviewers asked us to break down the current NCCN, which we couldn't do exactly because the NCCN is based on clinical staging and we based it more on MRI staging. But they asked us to provide what we could. And this is based on biopsy core numbers, MRI staging, PSAs, and the primary Gleason score. So a significant proportion of the patients do map out as unfavorable intermediate risk. But remember, this was not clinically done, so there's probably some overestimation of the unfavorable risk from the classic NCCN. So the results of the study. So it was designed as a non-inferiority study. And what we showed is that with conventional radiotherapy, biochemical control at 5 years was 94.6%, and with SBRT, it was 95.8%. This gave us a non-inferiority margin with an unadjusted hazard ratio of 0.73 and a p-value of 0.04, which demonstrated that this was non-inferior. There were 36 events, so either biochemical or clinical failure in the conventional arm and 26 in the SBRT arm. So if we look at the toxicity, this is RTOG GI toxicity. So in the table, it's the cumulative toxicity, but the graphs that we're showing show what happens over time. They are quite busy. The top line is grade 1 and the grade 2 and 3 are below. So I'm just going to take the grade 1 and 2 off, so grade 1 and 3 off, so we can just see the grade 2 toxicity, which is really what we looked at. So RTOG grade 2 toxicity was extremely low, following both treatment modalities, and the lines were completely overlapping. With GU toxicity, again, the top is grade 1, and the next 2 down are grade 2 and 3. Again, cumulative toxicity in the table. Over time, you can see that the blue line, the SBRT, is slightly worse between 9 and 18 months, but then goes back, and then there's no difference. And this is real. We do see this. You can get a flare in urinary toxicity with SBRT. Why it's graded as grade 2 is because it's prescription of an alpha blocker. So any patient receiving tamsulosin or an alpha blocker becomes graded as grade 2. This tends to be short-lived. And it does respond well to treatment. But I think it is, again, it's important that patients are told this up front, so it doesn't come as a surprise, doesn't happen to everyone, but it is real. So CTAE GI toxicity, again, rates were very, very low. Top line will remove. So this is just the grade 2. And again, you can see very low rates of GI toxicity, and the lines completely overlapping. If you'd asked me when we designed PACE, what was I worried about? I was worried we'd cause worse rectal toxicity. But in fact, that's not turned out to be the case at all. Rectal toxicity is extremely low. By the way, there were no spacers in PACE at all. This was done completely without spacers, and it was done across platforms. So the CyberKnife, Linacs. This wasn't machine specific. So rectal toxicity actually with SBRT appears to be very, very low. And for GU toxicity, again, this maps similarly to the RTOG. You can see there is a gap, and it's for the same reason, graded as grade 2 because of the prescription of an alpha blocker. It does settle, and at 2 and at 5 years, there was no statistical difference. So we concluded from PACE-B that the 5-year biochemical control rates were excellent, and that 5-fraction SBRT is non-inferior. Toxicity is low for both arms. And SBRT obviously significantly reduces attendances. It should be significantly lower cost to a healthcare system. And I think for this cohort of patients, so for patients who would be eligible within this study, I'm confident to say that SBRT can be considered as a standard of care. So thank you all. I'm very happy to stay on now. We've got plenty of time for questions. But thanks to all the patients who entered the PACE trials and continue to enter the PACE trials, because we have a PACE node study open, and we do have a new PACE study in design. So hopefully the PACE will continue to deliver trials for a number of years to come. And we've got an amazing team of people who make the PACE trials happen. So I'll stop sharing
Perfect. So congratulations again. As you said before, it's not happening frequently that a pure radiation oncology trial where 2 fractionations or 2 techniques are being compared make it into New England of Journal, which shows kind of the tremendous impact which this trial will have on our daily clinical practice. So congratulations. Anyone having questions, please put them in the chat and I will try to kind of work through it. I would start with the with a PACE-B trial and then move forward to PACE-A. There have been some technical questions, for example, about spacer OR. You mentioned it has not been used. There was also some mentioning of dose and fractionation. So how was this simultaneous integrated boost being applied? So you applied 5 fractions of 7.25 grade to the PTV and 5 fractions of 8 grade to the CTV. Was that being a homogeneous dose or was that being a typical SBRT dose with even higher doses in the center?
Yeah, so it depends on the platform. Obviously, if you use Linacs, it's more homogeneous. For instance, if you use CyberKnife, it's definitely more heterogeneous. So yeah, but the aim is to deliver the 40 gray to the CTV, the actual dose distributions. We didn't actually contour the urethra, and we didn't use catheters, but we tried not to sort of dump higher than 43 gray in the middle of where the urethra would be. So there was a sort of arbitrary constraint in a way, but we didn't have the urethra as a contoured avoidance structure.
One question, it was reported one of the intermediate in that analysis and was also being asked here. Are there any difference between the technology platforms in terms of safety, in terms of toxicity? Between CyberKnife and effectively NMCR?
Yeah, there was a difference actually. So when we started PACE, it was actually a CyberKnife only trial, and it was the initial funding for the study came from Accuray. Then Accuray had a change in management, and they wanted to reduce the costs. And so I said, well, they asked if we'd take on the sponsorship. They were the original sponsor. When we took over the sponsorship, I said, scientifically and for the study, it will make much more sense if we open up to all platforms. And that's what we did. And that was the best thing for the trial. Accuray then gave us an unrestricted grant. So they had no further input or any input into the design of this trial. They gave us the money to run it and allowed us to run it across all platforms. But we did plan right up front to do an analysis comparing the toxicity between SBRT delivered on a CyberKnife and SBRT delivered on a Linac. And that is actually published in our 2-year Lancet Oncology paper, which is first author is Alison Tree. And it is better, actually. Both the rectal and GU toxicity is better on a CyberKnife than on a Linac. We've done quite a lot of work to try and work out why. And it is actually quite difficult. And I think one of one of the reasons it's difficult is in a planning study, everything is static. Whereas what CyberKnife truly differs to the Linacs is you've got real-time motion management. And I think really what it's telling us is getting the dose in the right place with every fraction matters. And you're more guaranteed to do that with the CyberKnife because you've got the real-time motion tracking. If you have a Linac, and even if you do 2 arcs and before and after, you could have a 5-second gap where the prostate shifts by 0.5 centimeter. You wouldn't necessarily know it's happened, and potentially you're giving a higher dose without realizing it. So I think quality of the way you deliver the radiotherapy matters. If you have an ability to motion manage, great. But equally, even at the worst case scenario, the toxicity on a Linac was still very good, compared to historical trials. So even if it's not perfect, I think it's still very, very good. And I don't think you say you have to have an MR Linac or a CyberKnife to deliver prostate SBRT. I don't think that's the case. I think whatever machine you've got, you do need to make sure that you are using rigorous quality assurance, making sure you as confident as you can be that you are getting all your radiation in the right place every day.
There's also a couple of questions addressing the how could we identify and minimize toxicity? So one is obviously the delivery once daily, every day, every other day. Have you looked into this issue? I think I remember 80% of the patients were treated every other day.
That's
Did it
right.
make a difference in toxicity?
Yeah, quite early on, we did an early analysis, actually not just on our PACE patients, but on patients who we were treating with SBRT daily. And it does appear that the acute toxicity is a bit worse if you give it daily. Just chatting to some American colleagues who've done way more SBRT actually than I have, who've been doing it for longer and have very high numbers, they do choose to do it alternate days, but they also have patients who travel and they will do it in a week. Quite a lot of them, if they do it in a week, will give prophylactic alpha blockers. I have done it in a week, and I think similarly I have some patients who travel. If we do it in a week, I just tell patients for a short period things are going to be a bit worse generally. So I think the alternate day works really well, and we've got lots more experience doing it alternate days. But it's not impossible to do it in a week. But I think it is slightly worse in terms of toxicity.
In the publication you mentioned, the risk of toxicity, obviously cumulative, it's being higher in the SBRT arm for GU, and that might be in particular true for patients having higher baseline symptoms. I haven't seen the analysis. Could you elaborate a bit more? So what are patients being at risk having higher GU toxicity? Can we identify them? And could we, as you said, manage it by prophylactic tamsulosin, alpha blockers?
Yeah. So although it wasn't an absolute, so in our experience, if we use the IPSS score, if you've got an IPSS score higher than 18, then I wouldn't be hugely keen on using SBRT unless you can improve that. So we really try and optimize the urinary symptoms beforehand, either with medications or sometimes with a TURP. There's a bit of controversy whether it's best doing a TURP before or after. My own experience is better to do it before. Doing TURP after radiation, I think, leaves patients with a higher risk of incontinence. So we try and do it before. Gland size, again, is not a absolute contraindication. We had patients with gland size up to 120 mils. But if you've got an absolutely huge prostate with a massive median lobe, they're probably not the best patients for SBRT. They probably they may even be the occasional patient who's better managed with surgery. I think they're rare now, but there'll be some.
So IPSS of 18 is already quite high. If I have a patient with APSS of 18, I kind of take a step back and say, "Whoa, might not be an SBRT case." So what is the patient which you would kind of inform the patient that SBRT is equivalent, obviously, in efficacy, but also in terms of toxicity?
Sorry, I'm not quite clear what you're asking me.
So what is the kind of IPSS level or patient characteristics where you could truly kind of inform the patient that there's no increased risk of toxicity? Can we identify these patients,
Yeah, no,
or do we have to
I think,
consent all patients that they are at a slightly increased risk
yeah,
for toxicity at a few months after SBRT?
I think that's true. So we can't dissect out at this stage a cohort that are at higher risk because it was pretty consistent across the board. And to be honest, those of us who've done a lot of prostate SBRT, it is a consistent finding. You know, this does happen. So I think it's safer to warn patients that it may happen. Um, and you know, we try and optimize urinary symptoms on our conventional fractionation too. I mean, it's not that we only do it for SBRT. I think all patients do better with a controlled urinary symptoms before radiation, but it's not always possible.
There's another question about GTV boosting. Do you see any value, at least in the patient population which you've investigated? One might say 96% biochemical control at 5 years.
In going beyond that, so
Yeah,
in
going
doing
beyond
a
5 fractions of 8, or restricting the
yeah, that's
dose
a very good
escalation
question.
to the GTV.
Yeah, so when I mean, we designed another trial called Spark, a very small study where we did a focal boost up to 47 gray, because I thought that would be the next step beyond pace. But you know, with the control rates we're seeing and very, very few in-field failures, I'm not sure that we could justify going above that at this stage. PACE C is the higher risk group of patients. Okay, so when we've got the results of PACE C, I suspect there will be a cohort of patients who fail locally, and there will be a patient cohort of benefit who would have benefited from a focal boost. How we detect who they are, I don't yet know. You know, we've seen the flame study and the hyperflame study, which did show better outcomes for focal boosting in both conventional and hyperfractionated treatments. But in our experience with 40 gray, we're seeing very, very few. So I think the jury's out. At the moment, we're not routinely doing it. And I'm not going to plan to do it in terms of a trial until we have PACE. Alison Tree, who many of you will be familiar with, who's a close colleague of mine who was very involved in PACE and is doing quite a lot of work on the MR-Linac. She's looking at doing a de-escalation study where you escalate the tumor within the prostate and you de-escalate the rest of the gland down to 30 gray. So trying to minimize toxicity whilst not compromising outcome. And that trial's called Destination. And it's an MR-Linac study. So, you know, I think there's still work to do. We haven't signed and sealed the way you deliver prostate radiotherapy. Although, when my statistician Emma Hall, who's been fantastic in all the PACE trials, when she phoned me with the PACE B results, she did say it is going to be very hard to do the next study on intermediate risk disease because, you know, it's toxicity is low and control rates at 96%. It's not going to be an easy space to improve outcomes. So I think really we're going to need to look at how do we continue to improve toxicity. Is de-escalation the way forward? It may well be, but yeah, we're not going to stop. But I don't think there'll be another straight comparison like PACE B was done. I mean, I don't think we'd invest 1,500 patients, which is what it would take to do 5 versus 2, for instance.
There's a couple of questions in the chat about the reason for the GU toxicity, bladder or urethra. Do you have any kind of feeling? I mean, obviously you don't have any data based on your study. You did not do any catheter for demarcation of the urethra. You did not do any sparing. But would you expect the toxicity comes more from the bladder or the urethra?
It's a very good bit. Again, something we've discussed at length, and all the studies we've looked at, we can't prove that it's urethra, despite trying. I think it probably is a combination, and I don't think it's one size fits all for every patient. I think bladder neck is probably important. So I would suspect it's more driven by bladder than urethra, but they both probably, you know, they, they will both play a role.
Maybe switching gears now and changing over to PACE A trial. To me, the kind of most surprising, interesting finding was the difference between patient-reported outcome and clinician-reported outcome. That in terms of incontinence, there was hardly any bother from the clinician's perspective, but patients were wearing a pad in 50% after the prostatectomy. Was that also for you the most interesting or surprising finding, or what was it
Yeah,
for you?
it was actually, it was. And it's, I do, and I have done for years, a joint clinic with the surgeon, and very good, excellent surgeons. But their patients don't always tell them when they are wearing a pad, just for, some of them, and even the surgeons, when we published PACE-A, they went on Twitter and said, these are just patients wearing one pad, which is true. And one pad might equal no bother, which again, in many patients is true. But one of the the radiation oncs went on Twitter and says, I don't wear a pad. Do you? And he said, so I think for a patient, it's just important to know. Some patients, the thought of wearing one pad a day won't worry them at all. For others, it would be really troublesome. And I just think it's it if you look at the surgical literature, when it's prospectively recorded and patient reported, this is it's very common to see this kind of figure.
Maybe you can make a comment on the expertise of the urologist performing the surgery. There's also been some comments, maybe they weren't experienced at high volume surgeons. I don't think this is being true, but maybe you can comment on that.
Yeah, no, it's definitely not true. So it's definitely not true. These are all high volume surgeons. In fact, the highest volume surgeon who recruited to PACE has done well over 5,000 robotic prostatectomies. So, this is not an inexperienced surgeon or surgeons. So, and I actually, if you genuinely ask a lot of patients who've had a prostatectomy, even if they're wearing a pad just because they're aware if they cough or sneeze, they might leak a bit, So that's real. That's the real world of prostate surgery. In fact, I almost think the more interesting difference was the sexual function. The discussion I have with patients, the two things that drive their decision for me are continence, and some will be fine accepting that they might have one pad and a bit of occasional leakage. Potency is by far the second driver. Not for all patients, but for those who want to be potent, it's a massive driver. And I think this data is really, really important for them. These men, first of all, it's important to say most of them are not going to die of prostate cancer. With either SBRT or surgery, some without treatment, yes, they may die, they may get metastasis, but most of these men are not going to die. And so therefore their quality of life beyond treatment is extremely important. And if potency is important to them, then they should know this. They should know that they have a much better chance of being potent after SBRT than they do after surgery.
Coming back to this comparison between surgery and radiation, I mean, obviously we have these three or four domains: obstruction, leakage, bowel bother, and the erectile function. One measure how one could combine this decision regret, I don't think this has been addressed or asked in the trial.
No, it hasn't been actually, and I think there's definitely work to do to and we're doing one of our fellows is working on a decision-making tool, which will hopefully help prostate cancer patients, with the very easy graphics about smiley faces and, and pads. So I think we can improve the information we provide to patients, and we are working on that. So yeah, I mean, I think hopefully this data, and not this data only, but plenty of the other literature out there, we can do better in providing information. But I think this randomized data you can't argue with it, particularly on sexual function, in my view. And it's the real world. It's what we see, So I see a lot of patients post prostatectomy who aren't potent and are upset.
I'm just looking through most of the question. I think we have covered most of them, and we are already at 5:40. Um, Okay, so I would call it, yeah, no, we've covered all. Again,
Good.
Nick, that was a fantastic session. Congratulations again. I think that is a hugely important contribution to our field, where we still sometimes have difficulties kind of to explain what is the advantages, but also disadvantages of certain treatments. I always a bit jealous of the communication in the UK. When I saw last year the 5-year results were being published, we were big on the media. This is something where we need to learn in continental Europe, not only do good treatments and good science, but also kind of communicate it to get it out into the patients and inform them about the opportunities we have. So congratulations again. Thanks everyone for joining and wishing you a good evening. Bye
Thanks
everyone.
again. Thanks
Hope
for
to
the
see
invite.
you
Bye bye.
all in December time. Bye.